talking about our hearing, but first, hospice. Next on Village in Motion. Well, we're here in the studio on this okay day. I think a lot of snow is going to melt. But it's Wednesday, January 27th, 2016. And it's looking pretty good outside. So we have a lot to look forward to for the end of this week and next week in the weekend. But let's get to the business of hospice. And I'm Mary McDonald, by the way, your host for today, as if you didn't know. And we have with us Kathy Craig, hospice manager, and Jane Gerald, nurse case manager.
Correct.
Nurse case manager, to get that right. So, and we're here to talk about hospice. Mm-hmm. It's a subject that a lot of people are afraid of and avoid until the last minute. Mm-hmm. But it's good to look into it and become familiar with it, mm-hmm. because it's not as scary if you know what it is. So why don't you talk to us about it?
Good morning, and thank you for having us on today. It's one of those forbidden topics. But I think we're fortunate in this community because we have peer-to-peer discussions that are going on that help others to not be so afraid. And the feedback that we've been getting regarding the hospice care on campus has been absolutely wonderful. I ran into somebody last time I was on TV, and she had mentioned that, they were just so grateful for the care that they're receiving. And of course, she gave some recommendations and thought that today, if we could talk a little bit about what the hospice benefit specifically covers. Because I think everybody knows that hospice takes care of you in the end of life, but they don't know exactly what's covered under the benefit. And Jane, you want to?
Well, I think the biggest thing in the beginning is if your family member is declining and you're seeing a significant change, it's a good talk with your doctor to say, should we be thinking about hospice? Because hospice can come and talk to you what the benefit covers and do an evaluation, and then talk with the doctor to say, this is what we're seeing, this is why we think they meet the criteria to be in hospice, and then the doctor can say, yes, I agree, and we can go from there. So it's a team approach. The patient or the patient's family is the leader of that team. We have a doctor that helps us out with orders and visits. We have a nurse case manager like myself that takes charge. So you're going to see the same nurse. That's the goal, so that you don't have to tell me the story and what the concerns are each visit. So we build from the first visit and keep on going to make sure that they're comfortable. We also have a social worker to find out what your end of life needs are. Some people have done lots of planning and they just need to tell us what it is. Others have some loose ends and they say, oh, I need to do this, or we haven't done that. And she can help get those things accomplished. We have pastoral support. Annie Smith comes in to find out what your spiritual needs are. Doesn't mean that it has to be prayers only, but it can be what your belief, what is your belief, how can we support that belief and go from there, and what would you want, when do you want help in addition. But as we were talking prior, our aides are such a valued asset to this team. They do more hands-on. As a nurse, I do symptom management, med adjustment, and all. But the aids are there between helping brush teeth, wash the body, get someone from in the bed to the chair. Sometimes it's just soaking the hands and lotioning and massaging. So our aids are, as you were saying, angels
Right.
to keep someone comfortable and to meet their personal needs. And let's see here.
They provide socialization, which is a big factor. At end of life, a lot of patients become more withdrawn. So just having that loving touch of that team member coming in provides, just so much to the plan of care.
And a lot of times that's a really uncomfortable situation, having someone bathe you and seeing your body and doing things that you've never had someone else do for you, and to do it in such a gentle, soft, calm manner so that you're not feeling self-conscious about what they're having to help you with, that you no longer may be able to do it all yourself. And then we also have volunteers. We have volunteers from outside the campus, and we have volunteers in the campus. And sometimes a spouse just needs a chance to go out to have their own doctor's appointment, and you don't want to leave your loved one unattended. So a volunteer sometimes will come and sit and talk, read, play card games, listen to music, hold hands. And it's just knowing that someone's there while you're out of the apartment taking care of your needs, because as a caregiver, that's hard work. And if you don't take care of yourself, you don't refill yourself up, then you're going to hit bottom also. So the whole team is about taking care of the family and the patient and trying to find out who needs what and how can we help. Not that we can always fix it, but we can talk through and see. It may be that you really need to talk to your adult children or your grandchildren, but we help be an advocate to listen, to see, tell you what we're hearing, suggesting items to see what you want to do about it. So,
And the best way that we can help someone enjoy the last days of life and put meaning to those last days, and sometimes put meaning to a whole lifetime of memories, so that someone is not feeling that they're going to be forgotten when they do pass on.
but just like Kathy Craig was saying, their last days, there's a lot of times that we are getting people only within days of the end of their life. And yet, during maybe the last 6 months, you're back and forth to the doctor every week because you've got a problem. And when you're seeing someone on seeing a doctor on a weekly basis, it should start to be a trigger. Geez, I'm in the office more than I'm home right now. Who can help me? And that might be a great time to say, hospice, come talk to me. See if I'm qualified to be a part of hospice, because I understand you're about not prolonging life, not shortening life, but giving me better quality of life so that you're home, enjoying your family, enjoying maybe hobbies, your symptoms, pain, nausea, no appetite. All these things can be worked on, and it doesn't have to be days to the end of life. Most people do know 6 months of hospice. There are people that are with hospice longer. Hospice is about continuous decline. We have to make it measurable, but it's about quality, and it's a Medicare covered benefit. Medicare covers hospice at 100%. This is not something that you're paying out of your pocket for, depleting your funds. Many times people actually see that their funds go a little bit further because some of the medications that you're currently taking are for the hospice diagnosis. So hospice picks up those medications. Hospice picks up other medications to make you more comfortable, because it's all about quality and comfort for the time that you have. So,
And the benefit also will cover Some basic medical equipment for comfort and safety. So if somebody needs all of a sudden a wheelchair or a walker because they can no longer go and walk the halls like they could last week or last month, we can bring that in for their comfort, for their functionality, so that they can be out and about. We can bring a hospital bed in and a protective mattress so that their skin stays comfortable and intact and they don't, have sores that develop. We can bring in shower stools, bedside commodes. So the team approach, we sit down with the patient and the family and we develop this plan of care, and the patient is guiding us with how they want to be taken care of in their last months and days of life. So it's very patient driven. They're the boss and they direct us, and our job is to advocate and help them achieve those goals and achieve those final moments that they want to have happen before they pass on.
And hospice is not in your apartment around the clock. So we want you to have as normal a life as possible. So the nurse comes in, makes an assessment. We may adjust medications after talking to the doctor. Many times caregivers say, oh, you're changing the meds up and I can't keep track of my husband's meds. As a nurse, I'll be glad to fill the pill box and write out a list if he's coughing, if he's got a headache, if he's got pain, if he's got shortness of breath. And I write down all the things that could be going on and what can be done about it. Not so that we don't come back, that you don't have to have us always there interfering in your time with your family. It's about empowering you to handle the symptom, but we're always a phone call away and we can come. Just like our aides come, but they're not there 24 hours a day. They come in, it's about hour, 15 minutes at a time, and it's, many times 2-3 times a week, maybe up to 5 times a week when someone is now staying in bed and we're really concerned about their hygiene and their turning ability. So we don't want anyone to ever feel that we're taking over. We're there to assist. And if we try something and you say, oh, that was not a good choice, we just reevaluate and change. It's all about what works. Every person reacts to medicines different way. And so if we try something to take care of pain, but it's too strong, we can back it down so that you're in a much better comfort level. Not too drowsy, but the pain as well. You get a feel for when it's going to wear off. When we keep track on a log, what it took to keep someone comfortable, then you can say, oh, instead of having to wait until someone's uncomfortable, let's go ahead and let's put it on a schedule, because looking at this, we took it every 4 hours. So then we put them on a schedule. And then we also look at medications that are longer acting, that you don't have to be getting up throughout the night to medicate them, that perhaps we can use a long acting that will last anywhere from 8 hours to 12 hours. And we have some medications that will even be put on for 72 hours, a little patch. So it's all about keeping people comfortable with less trouble from the family and not having to always have someone there in your apartment and feeling like they're intruders. And we don't want to be an intruder. We want to be an asset. Yeah.
So as Jane said before, our job is to evaluate and take a look at the best plan of care and options for care. So we are more than happy to come to anybody's home to do an initial evaluation. We can do a chart review, talk with the patient, the family, kind of figure out what the goals are and how they foresee the last months of their life happening so that we can meet their goals. We are down in Village Square, down on the terrace level. The number to reach us is 703-923-3122. So if anybody is interested in just having a team member come down, share the hospice benefit with them and do an evaluation, and then from there we can help them understand what options are out there for their care.
Yeah, well, my association with them was just great. I mean, he only he just chose to go off dialysis because the doctor said you cannot you can have dialysis, but you'll have to stay in the hospital for the rest of your life. And he said, no way.
Yeah, where's the quality of life?
Yeah. So we took him home, and 4 days later he was gone. But we talked about it before.
And you had him at home. You
Yeah.
had quality time. You could say the
he had
things.
so much quality family. We had everyone there, the grandchildren, and just it was a madhouse.
And think of
He
those
slept through it.
memories. Think of
Yeah.
the memories you made at that
Yeah,
point too.
yeah.
A lot of times people think of hospice as for only cancer patients, and hospice is about quality decline in life for many things. Many of us end up with heart problems, that you're living on oxygen,
Yeah.
or lung problems, and that you're now only able to get from bed to chair to the bathroom and all, and you can't even get out of the apartment because you're too short of breath. Of course, we have the cancers. We also have people that we see for Alzheimer's, that as they decline, they're losing weight, they're not eating,
no.
their skin is an issue. Your husband, you were saying, was coming off of dialysis. So the renal failure, when your body's not flushing everything out, and dialysis is a rough treatment, and at some point in time it gets harder and harder. So we have people with Parkinson's, when they're no longer able to eat and talk easily, and they're having to change the consistency of their diet, and they're having more and more problems with choking and harder to communicate. That's telling us decline. So there's so many conditions that hospice can treat for at the end stage of those conditions. So I advocate for families to talk to their doctors. Is this something that we should be thinking about? We're here seeing you every week or every other week, and you're always adjusting these meds, and we're not really seeing much improvement. Is it a time that we should start talking to hospice?
Yeah.
And your doctor could give you some guidance on that.
Well, that's always think ahead. Don't wait till the last minute. Well, we fairly knew what was going to happen.
And
so-
likewise, you don't have to get your doctor's approval. You can always say, I'd just like to get the information. Can you look at my husband's or my wife's, or it could be adult children. Can you look at mom and dad's records? Do they meet criteria for hospice? And then we would go to the doctor and say, this is what we're seeing. This is what we think. What do you say? So,
Well, I think we're going to have to wrap this up
All
for
right.
now, and you'll have to come back and go on, and, because there's probably a lot of questions that people have in mind that
And
they always do.
we welcome them. And telephone calls, or meeting in the hallway, stop one of us and ask the questions. And it's always good feedback too, because then I can bring it back and share it with the community.
Right. Well, thank you very much. I didn't have much to say, but that was good. Easy day.
Well, thank you again for
You're
having
great to
us.
have
Thank
you.
you.
Thank you very much. So let's call it a day for now for you, and we'll have a video roll in on hearing loss with Marie Lee.